You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for November 16th, 2018, and this will be an AHA recap show. The first topic is the REDUCE IT trial. Now, I don't know about you, but I'd almost forgotten about triglycerides. The REDUCE IT trial has changed that. Triglycerides are back in. This was a randomized controlled trial, RCT, of greater than 8,000 patients, and it compared a highly purified fish oil called icosapent ethyl, or pure EPA, at a dose of 2 grams BID or 4 grams daily versus a mineral oil placebo. Now, the enrolled patients had to have a high cardiovascular risk and high triglycerides despite statin use, and the primary endpoint was a typical composite of CV death, MI, stroke, coronary revascularization, or unstable angina. The results were clear. 17.2% in the EPA group versus 22% in the control group. That's an absolute risk reduction of a massive 4.8% or NNT of 21. And importantly, all the components of the primary endpoint were statistically lower. It wasn't just soft endpoints driving the results. Now, there were other strengths of REDUCE IT, and this includes well-balanced groups. The 25% relative risk reduction is robust. The findings showed a consistent effect in important subgroups. And the risk reduction in REDUCE IT comports well with the JELIS trial, which was a non-placebo controlled trial of Japanese patients, and that found a 19% reduction in cardiac events, but used a lower dose of EPA. Now, there were some side effects and adverse effects. A statistically significant 1.4% increase in AFib was seen in the EPA group. And there were caveats, and this included a concern that in the mineral oil placebo group increased the LDL and other markers, and thus maybe made the drug, the EPA, look better. But experts like Sanjay Kaul and Sek Kathiresan downplayed his concern, saying the rise in atherogenic lipoproteins would only account for a 5% relative increase in events in the placebo group, but that still leaves a huge gain. As CV trials go, this one was markedly positive, and the truth is, I did not expect it. I took the Bayesian view that all the previous trials had been negative on fish oil, and this would be too. But after the study, I interviewed Professor Jane Armitage from Oxford, and she is an expert lipidologist and PI of the recent ASCEND trial, and she did not feel these results were out of line. And in our interview, which is up at the site, she offered 2 reasons why she wasn't surprised. One is the degree of triglyceride lowering in the EPA arm aligns well with observational data that would suggest that the degree of lowering of triglycerides would give a relative risk reduction of 20 to 25%, which was seen. The second reason Armitage wasn't surprised was that the meta-analysis of fibrate trials, remember, fibrates are another triglyceride lowering agent, have shown relative risk reductions of 25%, if you include only trials that have patients with high triglycerides, like they used in REDUCE IT. So, my friends, I'm an evidence guy. This is high-level evidence of a robust benefit. We should use it, incorporate it. But, of course, another thing Armitage told me is that the vast majority of patients with high triglycerides can lower their levels substantially with, get this, weight loss, diet, and exercise. So the second topic today has to do with the cholesterol guidelines. Writers from the ACC and AHA released a new 121-page document with 72 new recommendations, and these update the controversial 2003 guidelines. And remember, that was controversial because it got rid of treating to targets. Now, I'm not going to go over 72 recommendations. Let me try and hit the highlights. First, there was no changes in secondary prevention. Use maximally tolerated statins. But secondly, numbers are back in now, and lower is better. So in very high-risk people, the recommendations are to aim for an LDL lower than 70, first with max statin, then ezetimibe, then PCSK9 inhibitors. Now, for individuals with severe primary hypercholesterolemia and those with diabetes plus LDL greater than 70, they say don't bother with the risk score, just recommend statins. And there's big changes in primary prevention, and it's a stepwise thing. So step one is have a discussion of the pros and cons. Now clinicians will have to know the data, including risks of statins, drug-drug interactions, and of course, clinicians will have to figure out what the patient preferences are. Step two is if the LDL is more than 70 and the 10-year risk is more than 7.5%, start a statin, quote, if a discussion of options favors statin therapy. Step 2A is, unlike the 2013 document, which only used the risk calculator, this new document suggests considering, quote, risk-enhancing factors. Now, there's a bunch of these risk-enhancing factors, and they include family history, metabolic syndrome, chronic kidney disease, history of preeclampsia or premature menopause, chronic inflammatory diseases, high-risk ethnic groups like South Asian, and many more. So step 3 is in these intermediate risk patients, that is 7.5 to 20% 10-year risk, the presence of risk-enhancing features favors statin use. Now, for a monster change, coronary artery calcium gets a big mention for 2 reasons. First is that in intermediate cases where the risk status is unknown, the guideline writers consider using CAC to improve specificity. And second place to use CAC is if the decision to use a statin is uncertain. Say a patient doesn't want to take a statin or may have had side effects from a previous one, you can consider a coronary calcium score, and if the score is 0, then you can forego a statin, and if it's greater than 100, then statins are indicated. Now, this is a good document. It's a fantastic document, but let me just make 2 comments first on the coronary artery calcium thing bothers me. We have no RCT level evidence that this test improves outcomes. All CAC data are observational. And in absolute terms, the CAC reclassifies people to the wrong category more often than the right category. And if you don't believe that statement, send me a note and I'll send you a short PowerPoint. What's more, this is my real problem. The use of statin drugs in primary prevention has been shown in RCTs to reduce non-fatal events. Now, you can argue about the degree of benefits, but it's RCT level evidence of benefits. Now the guideline authors are suggesting that we can use observational data to withhold a RCT-proven beneficial therapy, and to me, that's disturbing. Now, another caveat, another problem that I have is that the authors recommend using ezetimibe in addition to statins when LDL remains elevated before using PCSK9 inhibition. Now, obviously, leading with ezetimibe is because of cost. But if you really go to the evidence on PCSK9 inhibition is much more robust for risk reduction. Now, remember the IMPROVE-IT trial. That's the ezetimibe trial. This was a combination of ezetimibe plus simvastatin versus simvastatin 40. Now, simvastatin 40 is a straw man comparator compared to the potency of statins we have now. And in the PCSK9 trials, these were statin-treated patients who had consistent benefit for cardiac events. So I'll just close with a question on this topic. Should guideline documents be agnostic on cost and just consider the evidence? And if it just considered the evidence, wouldn't PCSK9 inhibitors be ahead of ezetimibe? Third topic is the VITAL trial. Now, the VITAL is indeed vital because it tells us something that we can tell our patients to stop doing. And as a clinician, I argue that knowing what does not work is as helpful as knowing what does work. So kudos to Dr. Joanne Manson from Brigham and Women's and her co-authors in the VITAL Research Group. Numerous studies have failed to show vitamin D supplements help healthy people be healthier, but these previous trials were small and they studied specific populations, and this was not so for VITAL. VITAL was a big trial, and really 2 trials with 2 separate publications in New England. So in one trial, the authors randomized about 25,000 patients without disease, so primary prevention, to either a combination omega-3 supplement. Now, this is 1 gram daily and a mixture of EPA and DHA versus placebo. And in the second VITAL trial, patients were randomized to 2,000 units of vitamin D or placebo. The follow-up was pretty long at 5.3 years. And the results are easy to tell you about. The omega-3 trial looked at cardiovascular outcomes, and it was a typical composite. and there was no difference, none. The vitamin D trial looked at both cancer outcomes and cardiac outcomes. Similar answer, no reduction in cardiac events, no change in cancer outcomes. So patients without vitamin D deficiency can stop taking vitamin D. Now of note, slight asterisk, the baseline average level of vitamin D in the enrolled patients was 31. Now, if you're going to take omega-3 supplements, I wouldn't take this formulation of low-dose EPA mixed with DHA. I would take the higher, more pure dose tested and reduce it. Again, this is good science, even though it's a neutral trial, it helps. Next topic is on the CIRT trial, CIRT. Dr. Paul Ridker is the Eugene Brunwald Professor of Medicine at Brigham, and he's worked for decades on inflammation and heart disease. And at AHA, he presented results of the CIRT trial comparing low-dose methotrexate versus placebo for the prevention of cardiac events in patients who had stable coronary disease and conditions that were associated with high inflammation, such as metabolic syndrome and type 2 diabetes. Remember, methotrexate is a nonspecific reducer of inflammation. And in an interview, Ridker told me, which will come up soon on the website, that no one knows how methotrexate works, but it clearly does in some inflammatory conditions. Ridker presented results of the CANTOS trial last year. This trial showed canakinumab, a more specific blocker of inflammation of the IL-1 beta pathway. It did reduce cardiac events by a modest amount. So both CANTOS and CIRT were conceived in tandem, two swings of the bat, Ridker said, a specific blocker and a non-specific blocker of inflammation. The results of CIRT were clear. The trial was stopped for futility. Methotrexate did not reduce events. Now, perhaps this is because methotrexate did not reduce any of the levels of IL-1 beta, IL-6, or high-sensitivity CRP. These are markers known to be on the specific IL-1 beta pathway. So Ridker put the trials together this way. He said, given the positive findings of CANTOS and the neutral findings of CIRT, inhibition of the IL-1 beta pathway of immunity appears to be the important one for atheral protection. And these two trials point directly towards future work, which will target upstream inhibition and downstream inhibition on this pathway. Fourth topic today is the ENCORE VT trial. Now, prediction is a tough game. Consider, for instance, how hard it would have been to imagine the internet before it existed. So when I was in medical school and college, we called people on the telephone and we paid 5 cents to copy journal articles from the library. And we got to the library, not through the internet, but by driving our cars or walking there. When I trained in electrophysiology, AF ablation and CRT were not even yet imagined. So that's the context I want you to think about when considering the work of Philip Kukulich, an EP, and Cliff Robinson, a radiation oncologist at Washington University in St. Louis, and consider their work on non-invasive ablation of scar-related VT. Let me repeat that, non-invasive ablation of VT. So the ENCORE VT trial, which was presented at AHA and simultaneous publication and circulation, was sadly presented off the main stage. And it continued the work of a 5-patient case series they had previously published in New England Journal of Medicine. This was now a 20-patient case series. In short, patients with treatment-resistant VT, so these were people getting ICD shocks, underwent targeted stereotactic XRT, aka X-rays, to the arrhythmogenic area of the ventricular scar. Now, this procedure went on without anesthesia, IVs, catheters. The patient walks into the theater and walks out. That takes about 14 to 15 minutes. And the results are pretty good. I would almost use the verb vanquished for the VT. Median ICD shocks before went from 4 to 0 afterwards. Now, yes, there were some late recurrences, but these patients were treatment-resistant VT. Previous ablations had failed. Now, one note on the methods. The procedure may seem easy on the patient, and it is easy on the patient, but the planning beforehand is significant. Patients have their VT induced with the ICD, so you can do an EP study non-invasively with an ICD. Then once the VT is induced, it's mapped with a multi-electrode vest that the patient is wearing. Then that electrical information is merged with a CT or MRI image, and that forms the target for the XRT. So this takes serious collaboration. And it's very, very early. But is this a possible shift in what it means to do ablation or to be a procedural-based EP doc? Kukelich and Robinson told me they were planning a larger trial, and guess what? Multiple big famous centers want in. So both doctors emphasized caution in this early work, and man, their caution was so refreshing. The final topic this week, this is a topic that comes up often in the clinic. So here's the story. A patient who has a dilated cardiomyopathy who has improved on medical therapy to have a normal EF, and now that patient wonders about coming off the meds. Do they still need the medications? You worry here both ways. You don't want the heart failure to come back. But on the other hand, you also don't want to give someone pills that aren't necessary for years. So thank goodness British researchers tested this question in an elegant RCT called the TREAD-HF study, and it was published in Lancet and presented at AHA. Now, this was a study in which 100 patients were randomized to either a slow and gradual withdrawal versus continuation of the medicines. And at the end of the 6 months, the control group crossed over and started drug withdrawal. So the endpoint was a relapse of the dilated cardiomyopathy within 6 months, and there were many ways to define this by EF or LV end diastolic volume or a rise in BNP or even clinical symptoms. And the results here were striking and clear as well. Over the first 6 months, 44% of patients randomly assigned to treatment withdrawal met the primary endpoint of relapse, compared with 0 of those assigned to continued therapy. And then after 6 months, the crossover group, 36% of patients met the primary endpoint in that group as well. So this is striking. And who were these patients exactly? Now, these 2/3 had idiopathic dilated cardiomyopathy. About 14% had a familial cardiomyopathy, and about 1 in 5, 18%, had a dilated cardiomyopathy to a trigger like alcohol, hyperthyroidism, or say remote anthracycline use. This is an important study clinically. I think it's revealing. Now, the authors note that there are some caveats. The imaging and lab investigations were blinded, yes, but the medicine withdrawal was open label, so there's possibility of bias. And they also caution not to over-extrapolate these findings to, say, groups that weren't studied. For instance, one that comes to my mind is AFib-related tachycardia-mediated myopathy. Once you get rid of the atrial fibrillation and the myopathy improves and the atrial fibrillation stays away, you may be able to stop these medications. But nonetheless, if you have patients like the ones in this trial that have idiopathic dilated cardiomyopathy or familial cardiomyopathy, it seems very wise to continue medical therapy. So a couple announcements before I close. First, This Week in Cardiology will take a week break for Thanksgiving and we'll come back in 2 weeks. Second, if you like this podcast, and I hope you do, please consider subscribing and giving us an evaluation so other people can find us. And finally, if you have questions or concerns or something we could do better, please let us know. Send us a note on the website or tweet us at theheart.org or at Dr. John M. So I'm grateful that you listened. Thank you. I'll see you in 2 weeks. This is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org on Medscape.